My name's Aaron Levo. I'm the Vice President of Communications and Public Affairs. I'll be moderating this discussion today. We appreciate everybody taking time out of your busy day to participate and listen in on this session. As always, this will be recorded and posted on the Hub for anyone that wishes to share it after the fact with people that couldn't be on or couldn't be available at this specific time. We've been working to get this new format of remote webinar up and running, and appreciate the patience of everyone, the organizations we've got to this point. Today we're packed with some information that again is based on what we've been hearing from our workforce and our physicians are of concern to them, questions that have been raised through the COVID question email line that again is available on the Hub. You can continue to send questions there, and we will continue to have these broadcasts addressing those questions in themes. Well, let's get right to it then. I have a panel I'd like to introduce to you. So on the panel today, we have our President and Chief Executive Officer, Rob McIsaac, Dr. Wes Stephen, the EVP, Clinical and Chief Operating Officer, Michelle LaRue, our VP Human Resources, Dave McCaig, our EVP Corporate Affairs and Chief Financial Officer, Kelly Campbell, our VP Corporate Services and Capital Development, and Kirsten Krull, our VP Quality and Performance and Chief Nursing Executive. So I'm going to raise the first question to you, Rob. This is a huge challenge being faced globally and locally. Are we ready for this? What are you seeing?
Well, I think you're right. We're facing a massive challenge as a hospital, and I don't think there's any point in suggesting that it's anything other than that. The virus is moving, has moved into the region that we're serving, so we're seeing incidences of confirmed cases increasing. And I think there's little doubt that looking forward, high numbers of patients are going to need our care in the weeks and months ahead. And many of those will need critical care. We haven't yet seen that tsunami happen here in Hamilton, but I think it's important that we not be lulled by this lull, that we need to be aggressively using this time to make sure that we've done everything possible we can to be as prepared as possible for when that big wave of patients hits. We are preparing quite literally day and night based on a number of possible scenarios looking forward. Based on our current projections, I think we will be able to handle the first wave of patients. But there will come a point, depending on the effectiveness of some of the social distancing and testing that's occurring in the community, there could well come a point where all of the hospitals in our region will be overwhelmed. I think it's important to acknowledge that, in facing this challenge, each of us is also dealing with a very personal, emotional toll that this crisis is taking on each of us. And it's hard to separate the impact that this is having on each of us personally from the duties and responsibilities and professional commitments we have at work. I think we need to really take comfort in knowing that we have a world-class team of people working at Hamilton Health Sciences and that we're all in this together. We all need to try to do our best to take care of each other as we make our way through this extraordinary time that's, it's certainly unique in my lifetime. I think our best shot at getting through this as well as possible will really be found in our ability to act as a team and to care for each other as we go through this and as we're caring for our patients. We will be asking a lot of people. That includes asking people to work in different roles and in different ways, being creative with our supplies and resources, and putting really firm measures in place to help limit the spread of the virus and to help maximize our ability to respond to it. Our leadership teams are working really diligently to help us be as prepared as we can be. We have full confidence in the experience and ability of those people working on the front line to help us to do our best as a hospital. We are not an ordinary hospital. We have deep clinical and administrative expertise. We're in a better position than many across the rest of the province to navigate this because of the resources and knowledge we have in hand. There's no doubt things are moving quickly, and that presents a challenge in running a hospital. We will, I make my strongest commitment possible for us to do our best to keep you informed of what's happening as we move along. I think that saying thank you doesn't really feel like enough these days, but I don't know what more to say to you other than I'm very grateful for all of the work that's going on across the organization to help put us in a place where we can do our best to take care of this community. So I'm going to turn it over to some of the other panelists who can provide updates on some of the things that I've been mentioning, and maybe Aaron, I'll pass it back to you.
Thanks, Rob. As you mentioned a moment ago, like the sentiment is, we don't know what to expect in terms of patient volumes, but we know it's going to be big and it's going to be serious. We think we can absorb the first wave of patients in some manner, but that's not been, that's not without a lot of effort and a lot of work. I wonder, Dr. Stephen, if I could ask you to comment a bit about how have we gotten to that point? What's driving decisions around creating that capacity? Who's doing that work, and what does it look like?
Thanks, Aaron. I would start off with saying that as the organization is aware, the incident management system or the site command centers and a corporate command center has been initiated and is meeting essentially almost daily. Within that structure at the enterprise or corporate level, Rob is leading a very dynamic group of people who are literally working nonstop and essentially in 5 major streams of work. I would think that the majority of people on this webinar would be aware of some of the work, but I think it's important to highlight some of these areas. The first one is being led by Dr. Lum and Bruce Squires, is around an ambulatory strategy. This is intentional to decrease the amount of foot traffic within our organization and in our sites. Over the last week or so, there's been a dramatic decrease in the number of patients coming for on-site ambulatory visits. This is recognized as an important strategy to create physical capacity in our ambulatory clinics and to decrease the risk of the spread of the virus. We recognize that we need continuity of care, and there's been a strong emphasis and pivot towards more virtual care, and a lot of work is occurring in this area. As well, this gives us an opportunity to redeploy staff in the ambulatory setting to other activities, which is going to be an important strategy for us to meet the increasing clinical needs that we anticipate. The second area is really the surgical and procedural work being led by Dr. Kelly and Les Gauthier. This is dramatically decreasing non-urgent or deferrable surgical or interventions. Last week, because of March break, it was a planned slowdown. We actually functioned at about a 15% normal activity level in our peri-op program. This week, we're somewhere between 40 and 50%. Of course, this takes significant pressure off the organization from a bed capacity point of view, which is another important strategy. The third component is really about building capacity, and that's a separate stream being led by Dr. Azam and Cheryl Williams. And they've done tremendous work in the last week looking at escalation of increasing needs and capacity building. And I would like to acknowledge that we've started a couple COVID medical ward for cohorting of patients. This is best practice. I would like to acknowledge the staff that are on these wards. I know that's an increased pressure and sensitivity for them to work in that environment. And on behalf of HHS, I'd just like to say thank you. The second level of that is to redeploy beds that we are achieving by not providing or deferring some of the scheduled care. Just so for people to be aware, we actually have 300 less patients across our enterprise than just 2 weeks ago. And this is why we feel we're well positioned to deal with the first wave. But we recognize subsequent waves of incoming patients in critical care and in the medical wards will require us to look for other different areas of providing that care. Some of that might be ambulatory space, some of that might be in less typical locations in our organization. Moving to the next strategy is really about decanting patients into the community. This patient population we are looking at is ALC and non-ALC patients. This important work is being led by Sharon Pearson and Dr. Mo Panju, and we're trying to bend the demand curve, particularly in areas of long-term cares, providing virtual care in those environments. And of course, all these difficult clinical decisions need an ethical framework. And I'd like to acknowledge Andrea Frolick and Dr. Ralph Meyer, who are helping us make these decisions about deferrable clinical care in a way that it fits the HHS core values. And they are doing tremendous work in supporting our teams in this area. So I'm going to hand it back over to you, Aaron.
Thanks for that update, Wes. It is certainly a huge effort and lots of people involved at all levels of the organization. That does give us some understanding of where the different foci are. One of the big questions coming in through the question line has to do about the changing policies that are happening in our workforce, in our space. It seems information changes so rapidly, sometimes it's daily. I mean, I guess Kirsten Kroll, can I ask you, can you talk a little bit about the clinical care guidelines? How are we managing that information given that it's changing so quickly?
Thanks, Aaron, and good afternoon, everybody. So there is a subject matter expert team that meets. It has a variety of different representation from specialties and so on, including a few folks from St. Joe's, actually. And what we're doing is producing quite a number of documents. Some of them are some of them are quite complicated, but we are, and you've probably noticed through the hub, that we are posting new policies and protocols that are intended to guide people and try and drive out some of the misunderstanding, but it is a way to make sure that we do get some consistency in the way that people are functioning. So what happens is that these documents are produced by the subject matter expert team, they get approved at the command center, and then we release them. And they're released in two ways. One through our policy library, where they are loaded. They would be accessible through that means. And then we're also creating the links through the hub under a button called Clinical Care Guidelines. So people can actually go through both means. If you go through the library, you would just search word COVID and you'll get a list of the different documents that are there. And then under the hub, you would just go under that button and you would see a number of the documents there.
Thanks very much. That's great. The hub is a central point, is a critical tool for us. One of the specific areas of evolving policy is around the use of masks, specifically the N95 respirator. Can I get you to expand a bit on that? Our current policy, what is it and what should people be doing?
Hi, Kirsten again. So certainly we acknowledge the concerns of staff and our physicians regarding the availability of our PPE and specifically the N95 respirators. We know surgical masks are impacted as well, but the respirators are the bigger concern for people at this point. We are currently, based on the direction from our infection prevention and control team and also the provincial government, the N95 masks are only required when we're doing airborne precautions or aerosolized material that would come from our patients. And again, this would include our patients who are being intubated and or extubated by anesthetists. You would have seen some documentation come out yesterday around the use of these precautions for aerosol generating medical procedures, both for patients who are with and without COVID. So that was described yesterday, and we'll continue to send more information as the days come along. But it is that is where the N95 masks are particularly important. We've also implemented new PPE policies in the Emerge department for them to address some of the issues that sometimes they're really not sure who's coming through the door. So if they anticipate some risk, they have some guidance there, and it's really about extended use of some of the PPE there. Another document in that regard will be posted today on the Hub and also in our policy library. In all other cases, including the general care of our COVID-19 patients, our droplet and contact precautions prevail. And of course, that's using the surgical mask or a procedure mask. There is certainly another discussion across many of the hospitals in Ontario with regards to universal masking. So that would be the notions of people wearing masks all the time. So at this time, we're not taking a position on universal masking at HHS. We are, of course, working with our regional partners to determine whether a regional approach is viable. The availability of PPE is an extremely important factor in these decisions as we face global shortages. Of course, you would realize they're worldwide. And we continue to review our PPE protocols against federal and provincial directions, and also in consideration of what's available to us. So we'll always continue to communicate changes as quickly as possible. And we really do need everybody abiding to those standards so that we can really make sure that this is available to the people who are on this teleconference today. It is about looking after ourselves, but also our patients. So I'm going to turn it to Kelly Campbell now, our VP for Corporate Services and Capital Development, to talk further about our PPE and supply procurement. Thank you.
Thanks, Kirsten. It's Kelly Campbell. As Kirsten has been talking about PPE, we certainly have been overwhelmed by the generosity of our community throughout this crisis. Each day we receive countless offers of support, both moral support, but also in-kind donations. In particular, we've been receiving a lot of offers for PPE donations and other supplies from various community groups. Our procurement team has established a central intake process so that we can review and follow up on all of these offers. That information was communicated in yesterday's daily dispatch update to staff, and is also available on the Hub and the HHS website in a PPE donation email inbox. We've also been receiving many ideas and suggestions from staff and physicians about innovative solutions to some of the key challenges we have, particularly around PPE and ventilator capacity. So we're following up on those, and through Kirsten and some of her team's work, excuse me, we're really following off on the innovative opportunities to secure particularly supplies of masks in different ways. We appreciate all the ideas that are coming in, and certainly encourage everyone to forward their thoughts, contacts in the community, and we're really trying to maximize those. We're working on a similar process to funnel other ideas, non-PPE related donations to the appropriate teams as well. So please keep information coming, and we'll communicate that centralized process corporately soon. As Kirsten mentioned, we can't overemphasize the importance of PPE conservation and the role that all of you play in your willingness to help with that, to be conserving as much as you can. Certainly where our community is willing to pitch in and help us, we're doing our part to take in those donations and add them to our existing supply, which is becoming limited, and certainly something we're following up on very closely. Now I'll hand it over to Dr. Wes Stephen, our Executive Vice President, Clinical Operations and Chief Operating Officer, to talk about our recently updated visitor policy.
Yeah, I think That'd be important, Wes. If I could get some comments on that. I know this is a recently new move, and it's a huge change. It's really making our facilities feel different. It's a different experience for our patients, but it's a huge contribution to containment, which we know is going to be something we're going to have to think about, not just for weeks, but for months. So can you put this in context for us and maybe talk about some of the unique circumstances where we will allow still some visitors?
Thanks, Aaron. Thanks, Kelly. As we know, at the end of last week, we closed our hospitals to visitors in an effort to limit the spread of COVID-19 in our facilities. Given that we provide care for pre-birth to death, it was obvious to us that some exceptions would be required. These include pediatric population, end-of-life care, life-threatening situations, or serious emergency surgeries. There is always an opportunity for exceptions to be authorized by the manager or a delegate, given that there's unique circumstances that a broad policy can never fully address. We know this is hard on our patients and their loved ones. We recognize this is, in some ways, a very draconian approach, but is necessary for us to try to control the spread of the virus to our staff and to our patients. I'd like to acknowledge the IE team and HITS team because they've enabled free Wi-Fi access across our sites, which allows our families to stay connected virtually, which we hope will somehow mitigate some of the emotional turmoil that this policy may create. But this is consistent with all other hospitals in the region and is a necessary step. So I'll turn it back over to you, Aaron.
Yeah, thanks a lot. I guess next I want to talk a little bit about some of our HR policies and some of the issues around return to work and testing for staff. These are questions we've been getting since day one. You know, we've had, I think as a province, we've right from the top of the province, we've from the premier all the way down, we've been seeing different directives throughout the March break period up until now. We know we've got a lot of people who have just returned from travel. Like what should people have in mind? Maybe Michelle Leroux, our VP of Human Resources, can I ask you to just expand a bit on some of the themes that are really critical right now around return to work and testing? And thank you.
Thanks, Aaron. Yes, as our staff and our physicians continue to return home from their vacations, we want to remind you that anyone returning from international travel must self-isolate for 14 days. And that 14 days begins on the day of your return. You know, only in rare and very exceptional circumstances will a staff member or a physician in self-isolation be called into work. And if that is necessary, these are conversations that will happen between that staff member and physician and their leader. On that note, currently staff and physicians are required to self-screen before coming on site for their shift. Effective today, effective immediately, staff and physicians who require COVID testing will be referred by our employee health services to our urgent care center for expedited assessment. So what we're asking of our staff and physicians is if you develop symptoms while at work consistent with COVID-19, and those resources are available on our hub, tell your leader and leave the workplace immediately. Report to employee health, either by the email that's on our website, covidforms@hhsc.ca, or at extension 42200. And if required, you'll be referred to the UCC for testing. As always, if you're not feeling well, do not come to work. Please stay at home, report to your manager and employee health services for further direction. On that note, I'll turn it over to Dave McCaig, our EVP Corporate Affairs, who'll give you an update on some work that's underway for our screening.
Thanks, Michelle. I really just wanted to reiterate that it does remain every staff member and physician's responsibility to ensure they self-screen daily. And that also includes ensuring you remain current on the evolving protocols of what that means. So, and again, as Michelle has already said, that is available on the hub. Now, we are working with a third-party group to roll out a user-friendly screening application, which would be web browser-based. The intent is staff and physicians would be able to complete their health screening via the application prior to arriving for their shift, and also allow them to pass quickly through screening stations. This work is in development. We hope to be able to roll it out this week. it is also going to be very critical information for HHS to understand the status of our workforce every day as we move through this COVID situation. So look for more information that will come out later this week. And I'm going to turn it back to Michelle or to Aaron.
Thanks very much, Dave. Michelle, Michelle Leroux, I want to ask you another question, in fact, around redeployment. Like what's happening? What was announced by the provincial government, and how is that impacting how we're functioning as a hospital?
Thanks, Aaron. On Saturday over the weekend, the provincial government did issue a new order under the Emergency Management and Civil Protection Act, which helps hospitals implement redeployment plans in response to the COVID-19 pandemic. So in short, it's a temporary order that enables our hospitals to carry out certain staffing measures, such as redeployment to different areas of the hospital, redeploying staff to work in a COVID-19 assessment center, changing schedules and deferring vacations. The order allows hospitals to redeploy non-bargaining unit staff to bargaining unit work, and different measures such as that. The hospital has created a central redeployment center, which is responsible for coordinating our staff redeployment. We're currently working through the requirements of this temporary order and developing structure and processes for redeployment. We understand that redeployment is disruptive to individual schedules, to our personal lives. However, these measures are necessary to ensure we can continue to provide care that our community needs. We continue to work closely with our union partners throughout this process, and we appreciate all your support and flexibility. Again, if you have any concerns about redeployment, we encourage you to speak to your manager, and more information is coming.
Thanks a lot, Michelle. We couldn't possibly get to every question that's been raised in the 30 minutes, and we want to be respectful of everybody's time and availability to listen to this kind of a broadcast. So we're going to conclude for today. I want to let you know again that this broadcast will be posted on the hub, so you can circulate that and listen to it with your colleagues or after the fact. Again, it's really critical that we base this on information that people need to know. So please continue to post questions to the staff COVID email that's on the hub. We're going to be back with another one of these sessions on Friday, and our goal will be to have them twice a week addressing those pertinent questions. So you'll see something come out with an invite to that. Again, really want to thank everyone for joining us and making time for this, and for all the hard work that's going on, and your personal courage and work and dedication to our community. So again, we'll be back on Friday. Thanks everyone, and stay safe.